When arriving on scene to a respiratory distress call, it can be very hard to determine what the issue is and the proper treatments for it. Respiratory failure falls under a large spectrum, therefore making numerous problems a possibility. Dyspnea, or shortness of breath, can be categorized into psychogenic and non-psychogenic hyperventilation. The root cause of non-psychogenic dyspnea usually involves cardiac, which is left ventricle failure, pulmonary, which can be obstructive like asthma, or restrictive. Pulmonary fibrosis is when it's hard to expand, and vascular is pulmonary embolism, or the movement of blood. Hematologic, severe anemia or lack of red blood cells, and metabolic, which can be CO poisoning. It is important to remember when doing a primary survey, when you're looking at the airway, you're looking for complete partial obstruction, blood, vomit, secretions. Listen for snoring or gurgling. For breathing, watch the chest rise and fall, look, listen, feel, also take breath sounds, and note rate, rhythm, and condition. While checking circulation, make sure you note the skin, look at the mucous membranes, and cap refill. Incidents that fall under respiratory emergencies are failure of ventilation, airway obstruction, neurological injuries, physical causes like ascites in pregnancies, failure of gas exchange due to toxic gases or COPD patients, pulmonary embolus, which is a blood clot in the lungs, myocardial infarction like heart attack, anemia, and lack of O2. In the case of an asthmatic emergency, the patient will first get a spasm in the smooth muscles of the bronchioles, followed by swelling and then thick secretions of mucus into the bronchial tree. Air is first trapped in the alveoli, then making it hard to exhale, leading to exhaustion, and then finally respiratory failure. Some of the causes of asthma can be extrinsic or intrinsic. Extrinsic is outside, so dust, pollen, smoke, animal hair, or other irritants, and intrinsic is inside, like infection, emotional distress, or strenuous exercise. Some of the signs and symptoms of asthma can be dyspnea, wheezing, tachypnea, tachycardia, anxiety, and apprehension. Some dangerous ones to look for is extreme fatigue, inability to speak, central cyanosis, and a heart rate greater than 130. Chronic bronchitis is caused by excessive mucus secretions in the bronchial tree, characterized by a productive cough, lasting 3 months of the year. Enlargement of the mucus glands can plug the airway, make mucus unable to move, and also cause inflammation. Some of the signs and symptoms of chronic bronchitis is a chronic productive cough, cyanotic complexion, shortness of breath, and frequent pulmonary infections. COPD, or chronic obstructive pulmonary disease, is triggered by low levels of O2. It can usually be caused by chronic bronchitis, emphysema, asthma, or any combination of the three. Signs and symptoms of COPD is TB, or tuberculosis, a heavy smoker over a pack a day, toxic inhalants, and also pollution. Emphysema. First, when looking at emphysema, the lung tissue loses its elasticity. Alveoli becomes trapped within air, the alveolar walls are destroyed, reduced surface area and contact for gas exchange, and gas exchange decrease, leading to hypoxia. Some of the signs and symptoms of emphysema are severe dyspnea, clubbing of the fingers, barreled chest, and accessory muscle use. Pneumonia. Pneumonia is an acute infectious disease that can be caused by bacteria or a virus and also affects the lower respiratory tract. It can be caused by inhalation of toxic substances. Signs and symptoms of pneumonia is that the patient will appear ill, have a fever and chills, dyspnea, splinting of the chest, crackles, and there will be tachycardia and tachypnea. Tuberculosis is a very contagious chronic bacterial infection. It can be due to living and working in close quarters with other people that have it. Some of the signs and symptoms is fever, night sweats, fatigue, weight loss, cough, and of course a chronic bacterial infection. A flail chest happens due to a massive blunt force to the chest. It can be more than one rib fractured in more than one place, or if the sternum becomes detached. A diagnosis is respiratory distress, pain on palpation, deformity on palpation, splinting, and hypoxia. Treatment is oxygen and ventilation if needed. Complete or partial sternum fractures happen to blunt trauma and usually impact of the steering wheel. Diagnosis is chest pain, pain on inspiration, pain on palpation, splinting, and the treatment is oxygen, ventilation if necessary, and also check for associated injuries like spinal injuries or other ones you may find in a secondary survey. Pulmonary contusion is usually due to blunt trauma, often seen with flail chest, and also penetrating trauma. The lung tissue becomes bruised and can develop 1 to 4 hours post-injury. The diagnosis is a respiratory cough, ineffective cough, hemoptysis, restlessness and aggravation, hypoxia, and treatment is oxygen and ventilation. A pneumothorax is when air enters the pleural space, causing a partial or complete collapse of the lung. Air can be from outside or inside, and it can be spontaneous. Usually happening from a penetrating trauma or a defect in the lung. Diagnosis can be respiratory distress, tachypnea, onset of sharp chest pain, and treatment is oxygen, ventilation, and rapid transport. An open pneumothorax, or a sucking chest wound, usually happens to penetrations to the chest. Diagnosis can be bubbling or a sucking wound, hypoxia, and also sucking on inspiration. Treatment is oxygen, ventilation if needed, tape the dressing on 3 sides only, and rapid transport. To diagnose a tension pneumothorax, you have to look for respiratory distress, a decrease in absent air entry on one side, tracheal deviation away from the affected side, JVD, hypotension, tachycardia, skin will be cold, clammy, and pale, there'll be cyanotic, and treatment is oxygen, ventilation if needed, and rapid transport. A hemothorax is when blood collects in the inner thoracic space. Diagnosis is cyanotic, respiratory distress, flat neck veins, hypotensive, cold clammy skin, tachycardia, and delayed capillary refill. Treatment is oxygen, ventilation if needed, and also treat for shock. Cardiac tamponade is bleeding into the pericardial sac. Blood accumulates causing pressure in the sac, which decreases ventricular filling. The mechanism of injury is usually severe or blunt trauma, penetrating trauma, and ruptured coronary arteries. The diagnosis is hypotension, JVD, muffled heart sounds, normal breath sounds, trachea midline, and respiratory distress. Treatment can be oxygen, ventilation if needed, and rapid transport.